Bismillahirrahmanirrahim. Foremost, I would like to thank the MSH 2021 Organizing Committee for the invitation to speak on acute myeloid leukemia in the elderly. Let us begin by touching on two fundamentals. What is meant by elderly AML and why is there such an interest in this age group? Despite the existence of some research and publication of elderly AML that confines their subjects to above 65 years old, in general, elderly AML refers to those above 60 years old. From the Malaysian National Cancer Registry, published 2019, leukemia is the sixth most common cancer reported with age-standardized incidence rate, highest among Malay male at 3.9 per 100,000 population. The incidence rate increased with age, and this was attributed mainly to a rise in myeloid leukemia, as can be seen in these age-specific incidence rates for both male and female. In short, myeloid leukemia is a disease burden of the elderly, consisting of approximately half of all cases. A little warning here, MNCR reported both acute and myeloid leukemia together. In general, when managing acute myeloid leukemia, achieving complete marrow remission is considered as the first stepping stone towards long-term disease-free survival, long-term overall survival, or even improved quality of life, and this remains true even for elderly AML. Despite discovery of new therapeutic options, as I will allude to later in this presentation, the most foreseeable and accessible strategy today in Malaysia is still the standard AML 3+7 induction chemotherapy or its variation. This chemo protocol, which is standard for younger patients, is referred to as intensive chemotherapy in the elderly due to its association with exceptionally high early mortality. MD Anderson reported an 8 weeks induction mortality as high as 36% in their cohort of patients above 70 years old. With certain patients' profile, that probability can rise as high as 71%. Yet, there are some of these elderly patients who achieve reasonably good outcome. In this model, patients below 80 years old with ECOG performance status of 0 or 1 having favorable cytogenetic profile with normal renal function is expected to have 16% 8 weeks induction death with 2 years overall survival of 30%. The reason for this exceptionally high early mortality and poor treatment outcome can be broadly categorized into two factors: host factors and tumor biology. Hence, there is a need to carefully select suitable patients to undergo intensive chemotherapy as a choice of induction treatment. For the elderly, the very first step in choosing treatment options is whether a patient is fit for intensive chemotherapy. If the answer is yes, then go to the left. Tumor biology will next come into consideration. Absence of poor risk karyotype, which is often not the case, supports the use of intensive chemotherapy. This is often followed up by consolidation high-dose RRC with or without high-dose chemotherapy and allogenic stem cell transplantation. The new paradigm here is in the use of maintenance therapy. At the same time, presence of specific genetic profile allow the use of combination targeted therapy along with intensive chemotherapy. Let me repeat the management algorithm for elderly AML as shown in this latest 2021 NCCN guide. First is to determine whether the patient is or not a candidate for intensive chemotherapy. If the host is considered fit to receive chemotherapy, then the algorithm to the left is chosen, boxed in red. Next is to determine whether unfavorable risk cytogenetic tumor biology is present or not, boxed in blue. In the absence of unfavorable cytogenetic, the treatment is either intensive chemotherapy alone or in combination with some targeted therapies as shown in the greens. Intensive chemotherapy refers to dosing of continuous intravenous cytarabine at 100 to 200 mg per meter square per day over 5 to 7 days in combination to various anthracyclines. On the other hand, if an elderly AML is unfit for intensive chemotherapy, then tumor profiling and drug accessibility defines the options. The new paradigm is in the use of combination venetoclax and hypomethylating agent. In the absence of venetoclax, options are limited. See the purple boxes. The options are limited to low-intensity therapy with hypomethylating agent alone, low-dose RRC, or best supportive care. How do we determine if a patient is fit or otherwise to receive intensive chemotherapy? Up till today, there is no single all-encompassing instrument to help us make that decision. Nevertheless, there are some ground rules that are taken into consideration. What are they? Absence of all these following features indicate fit to receive intensive chemotherapy. Top of the list is performance status. ECOG score of 2 or higher is considered compromised. Age beyond 75 is usually no-go. Having significant organ dysfunctions, comorbidities, long-standing antecedent hematological disorders beyond 6 months, and lastly, unfavorable tumor biology, all these factors have been independently shown to contribute to increase in treatment-related mortality. Unfortunately, the marrow cytogenetic results do not return in a timely manner to help in decision-making. And the longer we wait for the result, one faces the risk of deteriorating performance status over time. Hence, in the absence of karyotype result, all patients deemed fit for intensive chemo will receive intensive induction chemotherapy. Yet, we are still expecting close to 1 in 5 treatment-related mortality. So how can we improve on this? In this graph picked from a study by Walter et al., among all the listed factors, performance status was the most impactful single covariant in predicting treatment-related mortality in AML, followed by age. Most of us use the Eastern Cooperative Oncology Group criteria to assess performance status. Karnofsky performance score is another alternative. Generally, only ECOG 0 or 1 is considered eligible for intensive induction therapy. However, ECOG is a self-reported subjective data which has been shown to be at times inaccurate. In this study by Klepin et al. Carried out amongst patients with ECOG 1, a significant portion showed various disability. Almost 1/3 has impaired ADL and 1/4 impaired IADL. Similarly, 30% had objective lower limb physical impairment using SPPB score of less than 9. Hence, a not-so-comprehensive geriatric assessment which included cognitive function using 3MS, psychological testing mainly on depression, physical function including both self-reported subjective evaluation such as ECOG, ADL and instrumental ADL, as well as objective testing, hand grip for upper limb and SPPD for lower limb assessment, and finally, comorbidity evaluation provides a more accurate, comprehensive representation of patients' functional status. A battery of these assessments has been studied in elderly AML and can be successfully completed in 40 minutes. Barthel ADL evaluates ability to self-care. A score of 90% is considered impaired. On the other hand, instrumental activity of daily living looks at individual housekeeping functions, which evaluates in 8 domains. It is not the score of less than 8, but an actual 0 in any one of these items that matters. You'll be surprised how many men surrenders their finances to their wives. They should not be penalized. IADL having 1-0 has been shown in a sub-analysis to be associated with higher treatment-related mortality and lower overall survival. The short physical performance battery test evaluates static balance, gait speeds and lower extremity strength and endurance. Each domain given a score of 4, leading a total of 12. A score of below 9 has been associated with significant hazard ratio in mortality among elderly AML. Comorbidity refers to additional clinical entity that has existed or may occur during the clinical course of a patient with AML. The Hematopoietic Cell Transplantation Comorbidity Index, HDC-allo, is a modification of Charlson Comorbidity Index, CCI, where additional comorbidities relevant to hematopoietic stem cell transplantation patient population, among which obesity and active infection were added. For elderly AML, the HDC-allo is more sensitive than CCI in picking up comorbidity issues. A score of 0 for both HDC-allo and CCI usually indicate eligibility for intensive induction chemotherapy. Going by this table, a diabetic with serum creatinine of 180 micromole per liter will have scored 3. Out of 177 elderly AML above 60 who received intensive chemotherapy, the comorbidity score was inversely proportional to patient outcome. 64% of those who had a score of 0 achieved CR, with only 3% death within 28 days and a median survival of almost 11 months. However, a score of more than 2 resulted in 29% early death with a median survival of only about 5 months. Next, I want to touch on something which we may have often overlooked. This is a model created by the MD Anderson group based on a 2006 study in which 3 risk groups, low, intermediate, and high, were formulated based on numbers of adverse factors that were found to show significant hazard on multivariate analysis of close to 1,000 AML MDS patients above 65. If you have someone aged 65 with performance status of ECOG-2 and a creatinine clearance of around 45 mL per minute, the 8-week induction mortality, which stands at 36%, will increase to 65% if the patient was treated outside a laminar flow room. Please note that open ward induction chemotherapy has the highest hazard. If you have HEPA filter facility, then you need to prioritize availability for these cohort of patients. Due to the constraint of time, I will only be addressing 2 recent landmark studies that has significantly impacted upon AML treatment, the VIAL-A study and the QUASAR study. I am sure many of us are aware of VIAL-A study published in NEJM August last year, a phase 3 randomized controlled trial comparing combination venetoclax and azacitidine versus azacitidine alone in patients deemed unfit for intensive chemotherapy. It is rudimentary that before we delve into the outcome, to review the inclusion-exclusion criteria to determine if our patient fits into the study population profile. Although VIAL-A is treated as the reference for patients deemed unfit for intensive chemotherapy, the study population only included ambulating patients. The study did not include any patient who are bedridden at ECOG-4. Also not patients who are in CKD4 or liver enzymes above 3 times upper limit of normal. In addition, patients who has moderately severe cardiovascular disease as well as active ongoing infections were excluded. The median overall survival is significantly different, 14.7 months for the combination arm compared to only 9.6 for azacitidine alone, and the hazard ratio of that is 0.66 and statistically significant. In the combination arm, complete remission was achieved in 36.7%, sustainable over a mean duration of 17.5 months. A combined CR and CRI were achieved in 64.7%, almost 2/3 of patients, significantly different compared to 22.8% in the azacitidine alone arm. And this significance extended into molecular subgroup analysis of IDH mutations, FLT3 mutations, wild-type NPM1, and in TP53. However, in patients with poor cytogenetic risk response, the median survival showed no significant difference, 7.6 months versus 6 months. This is important. The NCCN guideline recommend the use of venetoclax-based therapy in this cohort of patients, but HMA therapy alone may be just as good. How long should the patient be on this treatment? The number of cycles administered was between 1 to 30 cycles, with a median of 7 cycles, 24% of which was interrupted due to adverse event. And the most common grade 3-4 AE, 30% of them, is febrile neutropenia. Dose interruption between cycles were common in 72%, and reduction in duration from 28 to 21 days per cycle in 53% of patients, and 32% need G-CSF support during remission. In other words, venetoclax and azacitidine may not be classified as chemotherapy, but it still requires vigilance and close follow-up. The treatment is to be continued until loss of efficacy or intolerance. I would think financial intolerance will set in earlier than drug intolerance. At the time this presentation was prepared, there was still no patient-assisted program for venetoclax as far as AML is concerned. At Rm 20,000 plus per box of venetoclax and Rm 5,000 for azacitidine, 1 year of treatment costs approximately Rm 300,000. QUASAR AML-001 is a phase 3 RCT comparing oral azacitidine every 14 days of 28-day cycle in patient with CR or CRI following intensive induction chemotherapy in patient more or equal 55 years old ineligible for hematopoietic stem cell transplantation. That they have had marrow recovery following intensive chemotherapy in CR or CRI and ineligible for allogeneic marrow transplant. Patient has to be ambulating. The maintenance arm showed significantly longer median overall survival at 24.7 months compared to 14.7 months and longer median relapse-free survival at 10.2 months versus 4.8 months. Unlike ALL, maintenance therapy has not been a standard of care in AML, as prior to QUASAR, there has not been conclusive evidence to show benefit both in overall survival and disease-free survival. QUASAR is a landmark study that redefined the treatment strategy. Unfortunately, oral azacitidine is not yet available in Malaysia. What does that leave us with? I'm putting up this study not as a recommendation but as points to ponder. This is a small observational study from Korea involving only 57 AML patients who was prescribed maintenance 50 mg 6-MP daily and 10 mg weekly MTX for 2 years after CR or CRI or until relapse compared to historical control. The median overall survival for the maintenance arm was longer at 43 months versus 19 months. It may or may not be significant depending on which statistical analysis was chosen. What is interesting is that in the sub-analysis of elderly AML, the maintenance arm showed significantly better hazard ratio of death at 0.22%. Question: can this be a viable alternative? How long do we have to wait before we get to see the global therapeutic progress gets translated locally? For those of us who are approaching the elderly age bracket, we share similar views with most of other elderly Asian patients who are also parents. All throughout our lives, we have applied altruistic attributes in the upbringing of our children, our progeny. Many of our life decisions had centered around their well-being. These included accumulation of assets and wealth to assist them in their startup during early adulthood. Me and my colleagues practice in a Muslim predominant population in Northeast Malaysia who embraces this hadith. If one aged into 6 series and for some reason made aware that one has acute myeloid leukemia, it is often considered that the means of one's imminent departure has now been revealed. It is time to go. It is time to hasten the transfer of resources to the intended parties. How many do you think is prepared to divert their savings, approximately Rm 300,000 plus for venetoclax and azacitidine. In the end, it all boils down to how well the treatment options and the possible outcomes has been communicated to the patient. Ideally, it should be a shared decision-making whereby both doctors and patients negotiate for the best option in the patient's perspective. The patient makes the call with appropriate consultation. This engagement must be at a senior level. Lastly, we also should not forget that a 65-year-old individual may be physically dependent to his children or other family members providing support, taking a role as a surrogate. Any discussion must involve them as well. Hence, it becomes a tripartite relationship. Unfortunately, in such model, the final decision may not be in the interest of the patient, but that of the surrogate. With that, I end my talk. I would like to thank all the members of the hematology unit at HUSM, without whom we would have failed to deliver. Thank you.